Good morning all. I think some hangover for the previous dinner, a fantastic dinner. And I'm starting off with the most tough talk I have ever given, thanks to Srinivas. I am myself not very sure that if I'll be able to do justice to this talk. I'll be talking about the cognitive balance and solving issues in obstructive sleep apnea. We have not gone much into it, delved more into it. We have always been talking about prevalence of OSA and its cardiovascular, neurocognitive, pulmonary comorbidities, and the kind of the motor vehicle accidents and all which happens because of OSA. But there are other certain things also which are still unexplored, researched, not much researched into, but they might be playing a very important role, and especially in elderly, the things which we are not able to think of, balance disorders, patients coming to us that they are already kind of having dizzy, imbalance, but we are not able to find any cause to this. So maybe we have not gone into it. Obstructive sleep apnea could be one of it. So it's very much into the initial research and of course due to the paucity of literature. But after I was given this talk, I decided to do a few patients, thanks to my audiology colleagues, Dr. Nuran and Mr. Sadbir Singh. So we have been, just for this talk, we did a few patients just to see whether what we have seen in literature, is it true or not. No, the cognitive function can be seen by the ERPs. They assess the cognitive processes, and this can be extracted from the encephalogram by time domain analysis. And P300 is a very important way which we see, and it is the conscious interaction of the auditory system with the somatosensitive cortical area. It's too much of details into it, but the bottom line is that patients with profound OSA and severe OSA without somnolence had longer P3 latency, and predicted OSA sufferers showed increased auditory N1 and P2 amplitude. Now, if we talk about P300 and N1 and P2, they are waves which are usually seen when we check for cognitive functions by ERPs, that is event related potentials, and the N1 and the N2 is at the 13 milliseconds and the 23 milliseconds. So that's what it is all about. We can't go into details of this. So another study which said that ERP studies have contributed to demonstrating changes in cognitive attentive processing in OSA, and it's mainly in association with altered functioning of the prefrontal cortex. And the CPAP treatment may improve vigilance and attention for these patients. So again, the ERPs have been, it has great potential to tell us about the cognitive functions in this people. Another study which says that association between ERP abnormality and EEG found that the late portion of the P300 was associated with an increase in the theta power of OSA. In short, it means that it correlates with the OSA. Now, what are ERPs like? They give a stimulus of, what we do is we give a continuous stimulus of kaka kaka da 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 to this patient, and intermittently between the da 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 there will be a gaga gaga. So the patient has to pick up, if the brain picks up that gaga between the kakas, so that is what the wave comes, that is the P300. So that is in short and summarizing. Now again, another P300 amplitude was lower in OSA group. So there are a few studies which says that cognitive functions does get affected in OSA patients, OSA sufferers, and so this is one thing which can be thought of. Now we talk about balance disorders. We all are knowing what VEMP is. VAMP is the vestibular evoked myogenic potentials. We might be doing for other causes, especially with our vertigo, the patients with vertigo, we are doing VAMPs in these patients. It's a diagnostic tool to evaluate the function of the saccule and the inferior vestibular nerve, which are responsible for detecting vertical head movements and maintaining the balance. So if there are two types of VAMPs usually, the cervical VAMPs and the ocular VAMPs. So we looked at the cervical VAMPs, which will give us the saccular function and the inferior vestibular nerve functions. Now, patients with severe OSA and who experience repeated airway soft tissue collapse, it leads to a nocturnal low O2 desaturation, resulting in sympathetic nervous system hyperactivity and neurocognitive function impairments. This hypoxemia will have a negative effect on the brainstem, and those which control the respiratory and the cardiovascular functions. Now, due to the anatomical similarities between the vestibular and the cochlea functions, this may result from hypoxia causing sleep disruption and the apnea. And this would eventually lead to damage to the vestibular hair cells and their related neural pathways. These impairments will affect the neural response to sound stimuli and result in further electrophysiological changes in VAMP. I know it's a bit boring, but this is what we will be maybe talking about more in the coming future. Now, if you look at this publication about impact of obstructive sleep apnea on balance, gait and fall risk, again it shows that the OSA patients have impaired posture and balance and gait with nocturnal hypoxemia. Now this may include the physiological functions, including the vestibular, muscle, visual and cognitive functions. And it postulated that the OSA impacts the balance by affecting these different systems to various degrees with a nocturnal hypoxemic burden, which might play an important role in gait-related disorders. Many of the patients, elderly patients, I don't know, I see a lot of patients who will come with, dizziness, that they feel their gait is not normal, they feel something is moving under the ground. You send them to a psychiatrist, a neurologist, ENT, you do your VNGs and everything is normal, but they are still having these problems, and we label them as functional and we send them to psychiatrists maybe. So we never thought of looking up, eliciting a history about obstructive sleep apnea syndrome. Maybe they are having OSA, and once we treat their OSAs, maybe this gait function, this balance disorders might go away. So that's the basic, the reason why this talk has been suggested. So again, this manifestation of ocular and cervical vestibular evoked myogenic potentials in sleep apnea patients. The result of this study stated that the response rates of O-VAMPs and C-VAMPs in patients with severe OSA were significantly lower than the controls. So these have been all significant, the C-VAMP between the controls and the subjects, the OSA patients, they were found to be significant, statistically significant. Now comes the swallowing impairment OSA. We are always talking about swallowing post-surgery, but did we ever look at the swallowing before doing surgery? How was the swallowing function before we ever take up the patient for treatment? So individuals with OSA have swallowing related complaint, and there is a link between snoring and subclinical pharyngeal swallowing impairment. Very recent studies which have stated this. And there is evidence that people with OSA have reduced upper airway mucosal sensory function in their oropharynx. The pathophysiological mechanism is a local neurogenic lesion in oropharynx generated by the low frequency vibration of the regular snoring during OSA. So there is a overlap between swallowing assessment, subjective methods and objective methods, and we need to find out how is the swallowing affected. Now the subjective methods will be questionnaires like EAT assessment tool, EAT-10 it is called as, this is what we used to. Then of course the other questionnaires about OSA, the Verlaine, the stop bang and the Epworth. And the objective methods would be polysomnography, a home sleep or a PSG level 1 PSG, and a FEES, fiber optic endoscopic evaluation. So solving dysfunction related to obstructive sleep apnea, another study, this is an older study done in 64 patients, which stated that the OSA patients presented premature oral leakage and pharyngeal status of the food bolus during swallowing. So it's not something new, but enough attention was never given to this. Dysphagia symptoms in obstructive sleep apnea, prevalence and clinical correlates. This is the latest one, and they used the EAT-10 score, a huge study, 951 patients, and the patients with OSA exhibited bolus location at swallow onset, greater pharyngeal and residue, and higher frequency and severity of penetration and aspiration events in healthy subjects. So again, the OSA patients have swallowing issues. Now the subjective way would be a EAT-10 questionnaire, and the objective way would be a FEES. We are using FEES for other things also, but we can objectively see the patients for swallowing disorders in obstructive sleep apnea also. Now this study, this said that the OSA patients have greater sleepiness, anxiety, depression, concomitant gastroesophageal reflux, and the independently associated with dysphagia patients. Gastroesophageal reflux has been already clearly established. We have just finished a study about association of reflux and OSA with the 24-hour pH manometry. I think Srinivas is also doing the same thing. So we'll be publishing our results very soon about it. And EAT-10 score of more than 13, it says that patients with OSA would have dysphagia. So just for this talk, we did a very brief study, a pilot study, 12 patients of OSA and 12 controls, 24 patients. We were done, and we did the EAT-10 score, we did a CVAMP, and we did the ERBs in these patients. And of course, there is not much for statistical analysis because it's a very, very small study. The P300 was recorded in all the subjects and the control group, and it was absent in 22% of the study group. So 22% sounds a huge number, but only 2 out of 12 because it's a small study. And the latency and the amplitude of P300 was compared between the control group using the 2-sample t-test. And it was found to be significant. Both this P300 parameters were found to be significant, latency as well as the amplitude between the controls and the OSA patients. Then the CVAMP, again the latency and amplitude of P1 as compared between the control was compared, and it was significantly delayed in the study group rather than the control. Whereas there was no statistical significance between the N1 latency between the study and the control group. So this is but P1 latency is significant, N1 is normal, and the P1 to N1 amplitude again is very significant. For swallowing disorders, we could not do FEES. It was too short a time for me, but we did a EAT-10 score, and there was first EAT-10 score. They reported swallowing for difficulty for solids, and some for the 4 patients for swallowing in solid and liquid, rice and water, and in swallowing semi-solids also. So there was a lot of swallowing disorders also in the OSA patients. So that is in all. I'm running out of my time. So I would just like to conclude that OSA may cause significant alteration in cognition, balance, and even swallowing. And OSA can induce structural changes at the central level, resulting in impaired memory, attention, other cognitive abilities, as well as compromised balance and gait. And chronic OSA may cause irreversible damage at the central level, ultimately posing a substantial threat to an individual's long-term quality of life. Thank you so much.